we go. Right. Good evening, everybody, and welcome to Fertility Talk. Our last Fertility Talk was the World Fertility Day, and it's good to be back and have another talk. Today, we've got Dr. Abri De Bruin, and he is from Genesis Reproductive Centre. And you guys are out in Pretoria, am I right? Pretoria?
Yes, in the east of Pretoria at Mediclinic Kloof Hospital.
Perfect. Thank you very much, Dr. De Bruin, for taking the time out to join us. I know you've had a busy schedule, and we actually struggled to get you fit in. But busy is not always bad. So thank you for taking the time out to do this evening. And if you guys have any questions related to infertility, please send us a message in the comment section, and I'll be checking it through the talk. And we'll ask Dr. De Bruin to answer any of your questions you might have related to infertility. This evening's topic is cycles. I just want to get the correct thing. What we are saying, it is different stimulation regimes and why patient protocols may differ from cycle to cycle. So it's quite a mouthful, and we're just going to leave it to the expert to talk to us more about that. So thank you very much for joining us, Dr. De Bruin. Please tell us more about you, and please tell us more about this.
Thank you, Leanne. You'll see there's one slide that explains this very nicely. And how clear it is. So my main interests are fertility and then endometriosis surgery. So that's what I keep myself busy with every day. And yeah, so I've prepared a short summary of things because I'm just afraid that we might miss things. So I'm going to share my screen and just go through some of the slides and just try and explain on a basic type of way why things change and why things are different. It's a little bit the same as with the new COVID variant. Why is there now a new COVID variant?
Yeah.
Well, there's going to be a new stimulation drug on the market next year as well. So
wow.
It's a fluid situation. It's not stagnant.
Okay, so I have allowed you to share, and then you can go ahead.
So I'm going to go there. Are you happy with that?
I'm happy with that.
All right. So I just said ovarian stimulation. What do we stimulate? When do we stimulate? Why do we stimulate? And how do we stimulate? So the topics will be, it depends on what the diagnosis is. It depends on what do we want to achieve? How can we achieve it? And what are the different medications that we can use to achieve it? And then the big question is, what do we use when? So I thought of taking this picture and just to show you that infertility is as clear as muddy water. Patients ask me, so doctor, we're not conceiving, why not?
Yeah.
There are so many unknowns. If we haven't done an IVF and someone's trying on their own, I always ask them, they must answer 5 questions. And the 5 questions are whether the follicle that we can see on ultrasound after stimulation contains an egg. The answer is we don't know. Whether the quality of the egg inside that follicle, if it does contain an egg, is good or bad, we don't know. Whether the tube picks up the egg, we don't know. Whether the sperm fertilizes the egg, we don't know. How the embryo develops, we don't know because it develops for 5 days in the tube. And then what is the quality of the embryo that lands in the uterus on day 5 that needs to implant? And we don't know. So we can get those answers if we do an IVF on every patient. But does that mean that we need to do an IVF on every single patient? And the answer is no, because especially in our part of the woods, not everyone can afford to do an IVF. So we must be able to offer them some alternatives. So I think the most important thing to understand just is how does this stimulation work? Because we have people that conceive on their own. That means that they made their own hormones and their own follicles and their own eggs. So how does it work? So the first 2 areas are contained in the brain. So we have a gland in the brain, which is called the hypothalamus, which is not really important, which then produces a hormone called GnRH, which is also not that important, which then stimulates another gland in the brain, which is called the pituitary gland. And the pituitary gland then produces FSH and LH. Now, interestingly enough, in men, this is exactly the same. So we also have hypothalamus that produces GnRH analogs that stimulates the pituitary gland that also produces FSH and LH. But in women, it stimulates the ovary to make two things: follicles that contain eggs and a hormone called estrogen. And in men, that will be the testes that gets stimulated, that will then produce sperm and testosterone. But then you have another organ, because women always need to win. So you have an extra organ, and that is called the uterus. So the uterus gets stimulated by the estrogen. So the estrogen stimulates the lining of the uterus. So the lining of the uterus needs to be fine. The follicles need to be fine. So there are so many things that play a role, and the stimulation all works exactly on this axis. And we're mostly going to talk about medication that contains FSH and LH, because what we want to achieve is what we call controlled. So that means we don't just give you a script and send you off into the bush and say, go take this medication. So controlled, meaning that we will monitor it by ultrasound, ovarian hyperstimulation. So let's just first ask, what's the diagnosis? Why do you need fertility treatment? Now, unfortunately, the most frustrating part, but also one of the most common reasons, is we don't know. We don't know why the couple in front of us don't conceive. There might be just a slight male factor. We all get that semen analysis, and then the men look at the semen analysis and there are 400 things printed on it and they have absolutely no idea, and they only remember one percentage number, and that's what they think the percentage sperm is. And unfortunately, it's not that. There is a very easier way to figure it out and to work it out. But there might be a slight female factor. There might be a cervical factor, that there's an issue in the cervix of the uterus that does not allow the sperm in. You may have, most probably, the second most common thing that I see in practice is called polycystic ovaries. So there's a lot of patients outside with polycystic ovaries, and then there is a second condition called polycystic ovarian syndrome, which is not the same as PCO. So PCO and PCOS are two different conditions. Do you have endometriosis? The most common thing I see. Do you have adenomyosis, which is the nightmare of the fertility specialist? So that means endometriosis inside the wall of the uterus.
Yeah.
Are your tubes blocked? Easy answer, easy treatment.
Yeah.
Or are there severe male factors? Also getting more and more common. So we're seeing a lot more severe male factor infertility, where we just get sperm counts that are horrendous. And some of these people are easy to determine. They either had chemotherapy or they work with chemicals or things like that. But in the biggest portion, we're not going to know why this husband has a very poor sperm count.
Yeah.
And then, are we going to use donor egg?
Sorry, I was just about to say that two of the most common things that I'm seeing here is PCOS and tubal factors. And I think there are so many women on our page, on our in our group, that is actually would always ask about PCOS as well as blocked tubes. So I love the fact that you said, it's something that can be helped, especially the blocked tubes.
Yeah, with treatment and not with surgery.
Yes.
That's just very important to remember. The only blocked tubes that surgery will make better is when we have someone that had a sterilization. They have clips in their tubes. We can go in and we can cut out that clip and reanastomose the tubes. Or we have a distal blockage where there's adhesions or something like that, then we can see if we can get those tubes better. But if those tubes are damaged because of infection, you can't restore those tubal function, because it's not only a question of a tube being open, It's also a question of that tube has little hairs. And if you think about it nicely, the tube works in, the hairs in the tube works in a way that it takes the sperm in the direction of the ovary, fertilization takes place, and then those same hairs inside the tube then move the embryo from the distal part of the tube back into the uterus. So it's a to and fro movement of whatever is in the tube. So it's not only a question that the tube is open, but is it functional?
Yeah.
That's far more important. And then the other question is donor oocytes, but I'll explain why I say that donor oocytes is an important aspect of stimulation. So if we look at this easy picture, normal picture, so we have a uterus and we have a cervix and we have the tubes and we have the ovaries. So we can have cervical issues. We can have issues in the cavity, whether the cavity is normal or not, whether the tubes are patent, issues on the ovary, and then endometriosis will be inside the pelvis. There will be fibroids, adenomyosis inside the uterus. But those are all the factors that we're now going to discuss. What are we going to do to stimulate these ovaries? And another important factor is which of the sperm will win. And just to put into perspective, this is a very old picture of me. So I went to the party with my dad and came home with my mom. So if we want to, the question is, what do we want to achieve with our treatment? What is our aim? Then it goes back to the diagnosis. If we just have someone that says, Doc, there's not really a reason that that you could find, and the sperm count is fine, and there's not a huge lot of things wrong with me. Can we try on our own, but let's just help on with some ovulation, or are we going to do an insemination? Then we're going to stimulate those ovaries with low dose medication. We want a single follicle, minimal stimulation, and we can either use tablets, or we can use injections, or we can use a combination of the two. If we're going to do IVF or ICSI for a male factor, then it depends on the diagnosis. And for donor oocytes and oocyte freezing, we want to use the maximum safe stimulation protocol. So how can we achieve it? Now, just to show you why it's muddy, we can give extra of the hormones that the brain produces. Some medications will then contain that GnRH hormone. Some will block the GnRH hormone. Some injections contain only follicle stimulating hormone. Some medications will contain only luteinizing hormone. Some will have a combination of LH and FSH. Some medications are produced in the lab. Some medications are made from urinary hormones. Some hormones contain estrogens, and then some contain progesterones. So that's why I put that pie chart on. Someone asked me, so why did you put the pie chart on? Just to show that there's so many things that we can use, that it's not just a simple question of you go to the doctor and he's going, if you are 32 years old and you're blonde and your husband's got dark hair, then you're going to get medication A. It doesn't work that way. So why are there different medications? Because we need to address different issues. Some patients should not get hormones that contain too much LH hormone. So patients with polycystic ovaries are the one group of patients that we want to stay away from LH hormone, because they traditionally have a high LH hormone already. And with a high LH hormone, we want to stay away from that. We don't want to give them a stimulation that contains LH. Some patients should be on a ultra long protocol or a long down regulation protocol. This also depends on the indication. So if this patient has bad endometriosis or adenomyosis, we're going to use these ultra long or long down regulation protocols before we even get to the stimulation. Some patients are triggered by different hormones. So some patients you can trigger, traditionally we will trigger with HCG, but there are certain patients that you are not allowed to trigger with HCG. because they can develop a condition called ovarian hyperstimulation syndrome, which in some severe cases can even lead to death. So that is not, so there are certain things that are just black and white rules that you can and cannot use. Some patients, we want to have a single dominant follicle, and other patients, we would like to have as many eggs as we can safely get. So when on earth would we like to get as many eggs as we can safely get? We get a patient that's 18 years old and she's been diagnosed with leukemia or some other cancer and she needs chemotherapy. She was at the chemotherapist this morning. The chemotherapist said they're going to start the chemotherapy in 2 weeks. They phoned me and said, you have 2 weeks to get eggs. So I have one chance to stimulate this patient to get as many eggs as safely as possible so that she has a chance of having a baby later in life if she and when she survives this cancer condition. So what do we use when? So if we have a patient with polycystic ovaries, and there's a very nice picture of a patient and how their ovaries can actually respond if we stimulate them, you can see that there are 43 follicles in this patient. So some patients, and she was on a very low dosage of stimulation, and they will just explode, some of them. So for insemination or timed intercourse, where it's clearly just a question of the polycystic ovaries, we're going to use tablets. And some patients feel that the doctor's experimenting. The problem is, especially with polycystic ovaries, in some patients, you will give them half a, let's call it a Laradex tablet, not punting anything, but you'll give them half a Laradex tablet and they will make 5 follicles.
Yeah.
Other patients with polycystic ovaries, you'll give them 10 Laradex tablets and 10 days of injections and they will make no follicles. So we are always going to start at the lowest dosage, because in fertility, we have 2 main issues that we want to prevent. The one is hyperstimulation syndrome, and the other one is called a higher order multiple pregnancy. And that means anything more than twins. So patients, I always say, you have 2 hands, 2 breasts, 2 babies, but if you get to 3, then it becomes a problem. So for us from Fertility Society, we are very active in saying that there are certain guidelines as to how many embryos we can transfer, because this is what we want to prevent. So if you're going to do an IVF or an ICSI with polycystic ovary patients, those are the ones. So let's say, for instance, now the patient has polycystic ovaries, but she also has, the husband has a very poor sperm count, or he had a previous vasectomy. So he has no sperm, we have to go and find sperm. Then we must use FSH only medication. And then we're going to trigger with a GnRH analog. We're not going to give them LH, and we're going to freeze all those embryos. And we will then transfer those embryos in a following cycle. We will not transfer them in the same cycle because we're staying away from that HCG hormone. And the thing is, if you're pregnant, the hormone that you test is HCG. So we don't want you to be pregnant while you have all these follicles.
Yeah.
If we just have a patient that we need to do an IVF or an ICSI, we can use, there are certain guidelines as to what we use. And this also differs from unit to unit and from specialist to specialist. So you will have 3 specialists in one unit that will follow different stimulation protocols, what works for them, what they feel comfortable using. So we usually use a combination of FSH and LH at different times in the stimulation protocol. So we would prefer to have FSH in the beginning of the cycle. In the second half of the cycle, we will add LH maybe. And older patients, or patients that are called poor responders, so those are the patients that doesn't matter what you give them, they make 1 or 2 eggs. Those are the patients who will use a combination drug from the beginning and usually give higher dosages. But there's also a ceiling. So we don't go above a certain threshold. It's not that we usually give 3 ampules that are mixed and now suddenly for you we give 10 ampules. There's a ceiling as to when it goes more than that, then we're not going to achieve more. And then in patients that had a previous poor response, then we need to look at what did we give them in their previous cycle. or if they've decided they've got a poor response at this clinic, they're going to go to another clinic. They can just have that information and take along. We are always willing to give that information out because we don't want this patient to spend all the money again to make the same mistake. Is what medication did they use and how can we adjust that medication to try and see if we can't get a better outcome. Now, how important is age? Age is important, but there are actually a combination of 3 factors that play a role. The one is the FSH and LH hormone levels on day 2 of your period. So those levels should always be done at every cycle because they will change in every cycle. So patients wonder why do they have to do these tests over and over again, because they change in every cycle. AMH is anti-Müllerian hormone, and that is just a hormone that tells us if we do an IVF, how many eggs are we going to get? And that's easy. We're either going to get nothing, or we're going to get 2 or less eggs, or we're going to have a normal response, or the patient's going to have an over response. So it only helps us a little bit in the patients where we need to advise them whether they should look at getting donor eggs or whether we must be very careful and they should have a cycle where we're going to freeze all the eggs in any case. And then the antral follicle count is how many follicles do we see when we do the ultrasound during the patient's period. Now, these 3 things combine with age. And age is changing, but there's a guideline that says around 40, 41, the chance of success is decreasing and the chance of having an abnormal baby is increasing, and that line intersects at about that age. So people need to understand that if they are going to do these treatments at older ages, that they have a higher risk and that there are things that we can do to genetically test the embryos, but we can't test embryos for every single abnormality that there is. So we can't guarantee that this patient will have a normal baby because there are things that are not connected to chromosomes that cause abnormalities. So are there different stimulation protocols? Yes, there are, because if you just look at 2 of those springboks, and you can clearly see not that the one had a bigger sperm and the other one had a smaller sperm that won the race. It's just that not everyone is the same size. So not everyone is going to react the same. So we can't have a standard protocol for every single patient. Ultra long protocol, a GnRH analog protocol, an antagonist protocol, simple tablets that we use for ovulation induction. And then in some patients, you need to additionally give them estrogen and progesterones. Other patients, you don't necessarily need to do that. And medication given during the cycle can change depending on your response. So we can start with tablets for 5 days, get the patient back, do an ultrasound, see, okay, well, she responded great. We don't need to give her any other medication. We're just going to trigger ovulation. Or like 2 patients I saw today, give them tablets that didn't respond very well. Now we change over to injections. Then we recall them after 2 or 3 days, see how they responded. And we adjust the stimulation according to their response. So the final words before we get to the question is that there is no standard treatment for all patients, even if they have exactly the same reason for not conceiving. So medication that worked for your friend or family member will not necessarily be the best medication for you. And I have this with patients that smoke. Let's say, yeah, but I know my friend smokes and she's pregnant. Yes, but they did not struggle or whatever. Or my friend had this medication, why are you not giving me this medication? Because you have a different condition. You have a different reason why you're not conceiving. That's why we need to give you a different medication. The options are enormous. So the experience of the specialist or the unit is of utmost importance. Make sure you're treated in a registered fertility clinic and treated by a registered fertility specialist in reproductive medicine. Fertility treatment has huge impact cost-wise and emotional-wise. This makes and breaks relationships. So this is
Absolutely.
not something that should be done by general practitioners. This is not something that should be done by general gynecologists. These patients that require fertility treatment should be seen at a fertility clinic. Any of the good, well-known, registered fertility clinics, and I mean, they're all available on the website, or you can even just Google the HPCSA, and then you can go and click on your doctor's name and see whether he's a fertility specialist, because there's a little thing in his name, links to his name, that says he's either just a gynecologist or he's a gynecologist and a fertility specialist.
Yeah.
So those things are crucially important. And I think it's expensive, and it should be done by the right people that know which of these medications will be best suited for that individual patient's case. So my summary is, if there's a slight male factor or a cervical factor, and we're going to either plan timed intercourse or insemination, then we only need minimal stimulation, and that's usually going to be tablets or injections or a combination. If there's polycystic ovaries, those are the most tricky ones to stimulate, and we will most of the time start with tablets only and then add injections, or some people will start directly just with injections and no tablets. It depends on how the patient responds. Endometriosis, adenomyosis, surgery plays a big role to get rid of the disease, but if there's adenomyosis, you can't really operate a lot of that, and then they will have to have a long or an ultra long stimulation protocol where we down-regulate them for up to 3 months. If there's unknown reasons, we'll use a standard stimulation protocol. There's tubal factors, standard stimulation protocol, because there's nothing wrong with the ovaries. Severe male factor, again, there's nothing wrong with the ovaries. We just need to get eggs, so standard stimulation protocol. And if we're going to use donor eggs, so any patient that's listening that is a donor, they must remember that they must get a standard stimulation protocol, always an antagonist protocol, and they must always trigger not with HCG. They get triggered with a GnRH analog, but their doctor will know that. So that is just those patient donors, because we're not allowed to overstimulate anyone, but especially we can't afford to now get someone that's willing to donate eggs that lands in ICU with hyperstimulation syndrome. So there are things that we can do that we can prevent that. So my last slide is a slide that I took in Japan of the macaque monkeys. And I just want to say that there is hope and there are treatment options, and stay positive.
Awesome. Wow. Thank you, Doctor. I really understand why you did this. And while you're talking, I was just thinking, you were saying about, going to the doctor and saying, but why didn't I do this? And why didn't I get, that was exactly me. I was asking my doctor, but why didn't I get this? Because I read up about that and I should be getting that. And I completely understand why my doctor did what he did. So thank you for explaining that. And it's actually like a perfect talk. It was a really good subject that we chose. So thank you very much for that, Dr. De Bruin.
Big pleasure.
It's a pleasure. Have a great evening. And if you guys, anyone wants to get hold of Dr. De Bruin, he is at the Genesis Fertility Centre, and that is out in Pretoria. So Dr. De Bruin, could you please give them your details of how they can contact you, please?
They can contact me at Abri, ABRI with a dot, at global.co.za, or they can contact the fertility clinic, which is info@Genesis, like the first Bible book, ART.com.
Okay, perfect. Isn't .co.za?
Sorry, .co.za.
.co.za,
yeah.
that's correct,
Yeah.
yes.
I was thinking about Gmail.
Yes, sorry. And then also Dr. De Bruin, Genesis is on Fertility Solutions on our website. So thank you very much, everybody. And thank you very much, Dr. De Bruin. Have a great evening.
Thank
Goodbye.
you. Bye-bye.